I would like to thank the organizing committee for inviting us to this important meeting. Hopefully next year we will be in Cairo during the meeting. I would like also specifically to thank Professor Amal Bishlawi for including us all the time in her meeting. Thank you, Amal. So our presentation today is a combined presentation between myself, Ali Taher, Professor of Medicine at the American University of Beirut, and also Dr. Khaled Musallam, Chief Research Officer in Abu Dhabi and President of the INH in London. So it will be a combined presentation where we will be looking at the contemporary way to understand the management of NTDT, and specifically Dr. Musallam will have a closer look into anemia and iron overload in this group of patients. This is our disclosure, my disclosure, Khaled's disclosure. So let me first start with the molecular, very briefly, with the molecular understanding and the genotype phenotype association of NTDT or thalassemia in general. As we all know that the alpha to beta globin chain imbalance is the main problem in thalassemia. And as a result of this, patients will get ineffective erythropoiesis in the bone marrow and hemolysis when the red blood cell gets out of the bone marrow in the peripheral circulation. Both of these would lead to chronic anemia, and the anemia is of varying severity. And as also we know, this would lead also to iron overload. However, we have several other modifiers that will affect the severity of the disease. The inheritance of homozygous compound, homozygous or compound heterozygous of the globin gene, milder mutations of beta, co-inheritance of alpha, more effective synthesis of gamma leading to more hemoglobin F. So all of these will modify the disease, and as a result, the chronic anemia will be of varying severity. If you want to look at the conventional way of beta thalassemia, the phenotypes defined based on the clinical grounds with genotype association. So if you would like to look at this slide, you would see that the genotype would range from beta to beta silent, and then beta plus, beta 0, and at the end you will have beta 0, beta 0. And as a result of these genotypes, we will get the conventional phenotypes, which is the carrier, whether silent carrier or a regular carrier, the intermediate and the major. However, the clinical presentation will be from no anemia to mild anemia to moderate to severe anemia to anemia necessitating blood transfusion all through the life of these patients. This is why we thought that transfusion requirement should be a major component in classifying this disease. And as a result, it is now used to distinguish the two major phenotypes of thalassemia, what we call NTDT and TDT. If you look at this arrow, at one part, you would see that the TDT are those that require regular blood transfusion all through their life, and they cannot survive without blood transfusion. This is what we used to call thalassemia major. It includes beta thalassemia major, severe hemoglobin E beta, and hemoglobin Bart's hydrops. While at the other spectrum, you will have the trait, and in between you will have the NTDT, what we used to call thalassemia intermedia. Beta thalassemia intermedia, mild to moderate hemoglobin E beta, and hemoglobin H disease. This is very important group, and this is the talk of today. These patients will require blood transfusion at a certain time in their life. They might not require at all, or they might require frequently for growth, specific morbidity, and sometimes for surgery, pregnancy, and infection. Now, this is from our recent review, the beta thalassemia in the New England Journal of Medicine that was published a few months ago. It combines all of these, from the genotype, which I've showed you, to the conventional phenotype, to the clinical presentation, to the transfusional phenotype, and you would see clearly here that the transfusion requirement is either lifelong regular in the TDT or seldom or never, occasional or frequent in the NTDT. So this slide summarizes from genotype to transfusion requirement and shows you the modern way of looking into or classifying thalassemia. I will not dwell a lot on this slide. However, I would like to tell you that the disease progresses with age, and sometimes some of the NTDT patients who were never transfused or occasionally transfused might get transfusion at a later stage in their life frequently, and sometimes they became like TDT. So it is very important, and this slide is very important for clinical trials, because during clinical trials, we need to choose specifically, for example, those that are never transfused or occasionally transfused. This is an important slide. If interested, you could look at it in the American Journal of Hematology recent publication. So now we will move into the pathogenesis in the absence of transfusion. Our story started years ago, around 2005, 2006. It was published where, together with Professor Capellini, we have noticed that the complications in NTDT are different than the complications in TDT. We all know that in TDT, the heart and the liver and the endocrine are the most important. However, in NTDT, we noticed that we had leg ulcers, for example, we had thrombotic events, we had extramedullary hematopoiesis, pulmonary hypertension, hepatocellular carcinoma, silent brain infarcts. But this was all from an observational on very few patients from Milan and from Beirut. This is why we thought that we need to do a cross-sectional study that included a larger number of patients, around 584 patients with beta thalassemia, with NTDT or thalassemia intermedia from the Middle East, Italy, as well as Iran. And in this trial, which is the optimal care trial, through which, together with Khaled, we will be showing some data on this, it shows very clearly that, yes, these complications are not only case reports or in small series. However, from this number, once again, we have showed the pulmonary hypertension, thrombosis, leg ulcers, and other complications. Not only this, when we looked into these, the naive patients that were never transfused, not chelated, no hydroxyurea, no splenectomy, around 120 patients, it was clear that these complications increased with age and increase also mostly started after the age of 10. And this is an important number that you will keep on hearing during this presentation. So now I would ask Dr. Khaled Musallam to talk about, to continue the pathogenesis in the absence of transfusion, however, highlighting ineffective erythropoiesis, anemia, and iron overload.
Thank you, Ali. As Dr. Taher has just shown you, it all started, probably we took the investigation into the morbidity of NTDT backwards. We started looking at what is observed in the clinics, and then through large registries, we were able to document the incidence and the prevalence of certain complications. But then we wanted to understand why are these complications being observed at such a high rate, and specifically at a higher rate compared to transfused patients. So we started a translational and an observational study program, various studies that looked into different risk factors and how these actually can increase the risk of certain morbidities that we saw in the registry in the optimal care study. This is a schematic representation of the pathophysiology as we understand it today. This is again from the New England Journal of Medicine recent review that Dr. Taher referred to. And I will go through each and every one of these arrows actually on how we actually think these pathophysiologies or risk factors lead to the development of morbidity. The first thing we wanted to look at is the ineffective erythropoiesis itself, since this is the core and the hallmark of the disease. That's a subsequent, it's a subsequent of the actual genetic anomaly that's found in beta thalassemia. But as you probably know, it's very hard to measure ineffective erythropoiesis. It's not practical to do specific bone marrow biopsies, for example, on a large group of patients. So we had to resort to some of the available or known or suggested markers that could give some sort of sense of the severity of ineffective erythropoiesis. At the time we did the study, there were a lot of studies that looked into GDF15, growth differentiation factor 15, as a potential surrogate marker of the severity of ineffective erythropoiesis. And first, we found that the levels that we found in beta TI and in thalassemia intermedia patients was higher than healthy volunteers. And we also were able to link or to correlate the level of GDF15 in the circulation and the clinical severity of disease, as we measured it through mostly the multiplicity of complications. So the higher the levels of GDF15, the more complications the patient had, and you can see how strong the correlation was in this graph on the right. And then obviously ineffective erythropoiesis leads to chronic anemia, and we wanted to link anemia directly to the development of morbidities. So we started initially with a cross-sectional look. We took a group of patients between Italy and Lebanon, and we looked at just simply to see if there is a correlation between the level of hemoglobin and the development of morbidity in a cross-sectional look. And we were able, through ROC, receiver operating characteristic curve analysis, to identify two key thresholds, the hemoglobin above 10, and that was a threshold where none of the patients actually had a morbidity, and hemoglobin less than 7, where all patients actually developed some sort of morbidity, while all patients in between had a mixed picture. So we took this work forward to look at it in a more of a longitudinal way, because we're interested in the incidence of disease, so that we can tackle all issues of confounding that you might find in cross-sectional looks. And we were able to follow up a group of patients, not a big group of patients, but that was a very specific group of patients that was completely treatment naive. So they were not receiving any form of transfusion or iron chelation therapy. And we were able to look at the natural course of the disease accordingly. And it was clear, as you can see on both these figures, that the hemoglobin level of 10 that we identified earlier is a clear separator of patients who would develop a morbidity, whether it's a single morbidity or a multiple morbidity, compared to patients who have hemoglobin above 10. So all of the patients that had hemoglobin less than 10 developed a morbidity, and many of them developed multiple morbidity, while a much smaller fraction of patients with a hemoglobin more than 10 did so over an observation period of 10 years. And then we were interested to see, now that we identified the at-risk group, we wanted to understand if there is variation in terms of the hemoglobin change. So what's the value or the significance of a change of 1 gram per deciliter in hemoglobin in both direction, upwards or downwards, on this morbidity risk. And as you can see in these graphs, whether we look at it as a pure incidence or as a probability of morbidity, it was very clear that a change of 1 gram of hemoglobin was significantly associated with a difference in the risk. So the higher 1 gram extra or increase was associated with lower morbidity risk, and 1 gram per deciliter hemoglobin decrease was associated with a higher morbidity risk. And you will see, once we talk about novel therapies at the end of this presentation, that these values had a lot of contribution to actually how the clinical trials today that are investigating novel therapies in NTDT looked at hemoglobin in terms of an endpoint, in terms of change, or in terms of defining the eligibility and the at-risk population. Again, anemia was not only associated with clinical complications per se, but we also had studies that looked into the impact on quality of life and also on mental health in general. For example, this study in specific here, we looked at the impact of hemoglobin on depression, measured by the Beck Depression Inventory, and there was a correlation between lower hemoglobin levels and higher rates of depression in this patient population, especially our patient population in Lebanon. Specifically, anemia has been also an ineffective erythropoiesis, and the chronic hypoxia that entails can be directly linked to some of the morbidities like extramedullary hematopoiesis in general, which leads to the formation of tumors. We'd like to call them pseudotumors, anywhere almost in the body that have hematopoietic stem cell potential. And in many cases, we get these patients presenting to the emergency department with compression due to these tumors, those masses that are trying to produce red cells, although ineffectively, but outside the bone marrow, and they start these masses to compress the adjacent organs. And you can imagine if they happen, for example, in the spinal canal, that could lead to detrimental and emergency cases of neurologic defects. And also we've had many case reports in the literature of them presenting in the pleura, causing chest symptoms, or literally anywhere in the body. Leg ulcers are also common in NTD patients. That's why we always recommend during physical examination to inspect the whole skin, the whole integument of the patient. And they were also directly in most of our studies linked to the severity of the anemia and hypoxia. There is also a role for local iron overload and iron deposits. And these are usually present a very clinically challenging scenario where management of the patient is not straightforward, and multiple rounds of multiple therapies are needed before these get healed to some sort of level of satisfaction to the patient. Beyond anemia, so we looked at the effect of ineffective erythropoiesis directly. We looked at the anemia per se, also directly, and its impact on morbidities. The next risk factor or pathophysiologic mechanism that we looked at was iron overload. And the first question, at least for those who weren't exposed to the field of NTDT in the past 10 years or so, would be, why would we even think about iron overload in a non-transfusion dependent population by definition? And this is obviously, we need to give a lot of credit to colleagues in the US and Italy, like Stefano Rivella, Clara Canascella, who helped us understand how this pathophysiologic mechanism happens. And in brief, as you can see in this figure, that this ineffective erythropoiesis in the bone marrow, in some sort of way through an erythroid signal, allows the liver to understand that the body is actually in a state of requirement for iron, because some red cell manufacturing is actually required, and that actually leads to decreased dysregulated and decreased hepcidin production from the liver. And there is a cascade of events that are consequent of that, which mainly lead to increased intestinal iron absorption. And that leads to a state of iron overload. So in NTDT, the main source of iron overload is not due to these occasional transfusions that they can get every once in a while, but it's due to increased intestinal absorption through the mechanism that I just outlined. Our next question was, okay, if this iron is being absorbed at a higher rate from the gut, does it reach to any form of clinically considerable or clinically significant level and lead to actual morbidity? And that's actually, we've conducted over, I think, 10 studies to actually address that question, looking at each organ system specifically. So we were able to link iron overload, whether measured through serum ferritin or liver iron concentration, to a variety of morbidities in NTDT. Pulmonary hypertension, venous thrombosis, endocrinopathy, specifically liver disease leading to hepatic fibrosis and cirrhosis. And you can imagine we've done a lot of adjustment and multiple regressions in these studies to make sure that we're looking at the direct effect of iron overload rather than iron overload being just a marker of the severity of ineffective erythropoiesis itself. One note is that one thing that was interesting in our observation is that we did not we're not able to document any effects on the heart per se. So no cardiac iron overload, at least on the MRI studies. And that we believe that we don't know the real answer of why is that the case, but it is simply most likely because of the mechanism of iron overloading, and its storage is different from the transfusional iron overload. Although we do expect that with older patients and more severe iron overload, that you would start seeing effects in the heart, but at the moment, the most affected organs are the liver and the organs that are mentioned here. And lastly, we wanted to translate all of this knowledge into something clinically meaningful that has some sort of implication for management. And that also was through various studies. So the first one was we wanted to look into the relationship between serum ferritin level and liver iron concentration in this patient population. And the one thing we found, as you can see in this graph on the left, is that for the same level of liver iron concentration, you would find a lower serum ferritin threshold or value in an NTDT compared to a DDT patient. And that is because, again, of the mechanism of iron overloading, since most of the iron overload in NTDT gets stored in the liver, and actually the signal from the low hepcidin leads to a release of serum of iron from the ferritin stored in the macrophage in the reticular endothelial system. So that leads to relatively lower serum ferritin levels in NTDT compared to DDT, even if the LIC is the same. So then we said, okay, then if the serum ferritin is not behaving similarly, we need to probably identify thresholds for serum ferritin that require management specifically to be specific to NTDT. We cannot rely on the 1,000 and 2,500 NTDT. We need values specific to NTDT. And we did this ORIENT study, the graph in the middle, and we were able to identify the serum ferritin of 800 and above as the one that is most likely linked to morbidity, while serum ferritin less than 300 was the one linked to no morbidity related to iron overload. And these corresponded to liver iron concentration levels of 5 and 3. So patients with an LIC of more than 5 were the ones that actually had the highest rates of morbidity. And all of this knowledge together is the main background and evidence that allowed us today to, in the NTDT guidelines, for example, published by TIF, to say that iron chelation, so management of iron overload is necessary in patients who are above 10, because that's when morbidity would start happening, and in those who have serum ferritin of more than 300 or an LIC of more than 5. I will now switch back to Professor Taher to talk about the last risk factor that we looked at in our studies, hypercoagulability, which also completes a picture of why these patients have the morbidities that we observed in clinical studies.
Thank you, Khaled. I'll be highlighting the issue of hypercoagulability and the vascular disease in NTDT. It's a really very important morbidity, and it's a morbidity that we can prevent. And I have seen all through these years several patients that develop massive thrombosis after surgery or during pregnancy, where we could have prevented this clearly. And this is why now this is a very important topic that should be taken care of seriously, specifically that our patients are getting older. So why do the NTDT patients have more thrombotic events than the TDT patients, or why do they have more thrombotic events in general? This is usually due to the pathological red blood cells, and these pathological red blood cells, even if you remove the platelets and whatever and just have the red blood cells per se, you would see what we call a flip-flop mechanism where phosphatidylserine will occur on the surface of these red blood cells, and these red blood cells per se will act like thrombin generation, leading to thrombosis. Together with an endothelial damage, with increased platelet, together with those that are splenectomized as a risk factor, those that are iron overloaded, those that are anemic, all of these together are multifactorial that would lead to the thrombosis in this group of patients. But the most important would remain the pathological red blood cells. And this is when we did also during 2006 or a little bit earlier, a very large cross-sectional study where we looked at around 8,860 patients from the Middle East. And we looked into the thalassemia major and thalassemia intermedia and the thrombotic event. It was clear that the thalassemia intermedia have 4 times or 4% more than thrombosis than the thalassemia major. And most of these were either older than 20, some had family history, some, and the most important would remain the risk factor of splenectomy. Most of these thrombotic events were venous, whether DVT, PE, portal vein thrombosis, very common after splenectomy, superficial thrombophlebitis were all present in this epidemiological study. Also, another interesting topic that we've looked at, we thought that these patients are not transfused and somehow similar to the sickle cell patients. So let's look at their brain. And it was clear that these patients had white matter lesions, or what we call silent brain infarcts. And it was clear also that this will increase with age. It will increase in those that were splenectomized. It is more common in those that were non-transfused at all. So once again, through what Khaled presented and what I'm presenting, showing you that splenectomy is not really something good to do in these patients. And not transfusing them also is not very good, and we should know when to transfuse these patients. And also chelating them is really very important, because as you see, these are very important components in developing morbidities. So this was our study, and then we looked into the literature. Apparently, Karimi in Iran and 2 other studies have also shown that there is some white matter problems in this group. However, it was clear that those that very well treated did not have any what we called lesions in their plane. And after this, we tried to look into the characteristics of the patients that would make them at a higher risk of thrombosis, because ultimately you will get somebody, a woman that's going to get pregnant, a woman who's going to, or a male that will going into a prolonged flight, an NTDT patient who wants to do an operation. So it is really very important to risk assess these patients and try to look at the risks that will make them at a higher risk of thrombosis. Usually these are the patient's characteristics. So if they are NTDT, if they are adults, if they are splenectomized, if they have elevated platelets count, elevated nucleated red blood cell, meaning more ineffective erythropoiesis, low hemoglobin, history of thrombosis, all of these together would make this patient at a higher risk of thrombosis. And as a result, these should be receive prophylactic anticoagulation whenever needed. So what we decided to do together with Dr. Capellini and Khaled and Dr. Musallam, we looked into what we call the TRT-RSS, which is the thalassemia-related thrombosis risk scoring system. That is old age, not old, more than 35, hemoglobin less than 9, ferritin more than 1,000, not regularly transfused, and these were all scored. However, the most important score, or the highest score, was given to those splenectomized. So in my opinion, any splenectomized NTDT patient should be risk assessed for thrombosis very well and should receive prophylactic anticoagulation. Another important vascular complication is the pulmonary hypertension, and the pulmonary hypertension increases with age in those splenectomized, increases in those who are anemic, and in iron overload. So you have here two studies. The one on the left is the one that we did in Lebanon that shows that pulmonary hypertension is associated with an increase in LIC and serum ferritin. But the other one, which is on the right, is the important one from the WebThal, from a very large group of the Italian group, that showed that pulmonary hypertension also increases with age. Pulmonary hypertension is more common in those who are splenectomized, and this is how further we showed that pulmonary hypertension, if you looked at the number in TI, is 4.8% compared to 1.1% in the TM. So splenectomy, that was once commonly performed procedure for NTDT, is now mainly reserved to cases that have huge spleen, symptomatic splenomegaly, severe hypersplenism, because as we have shown you, that's not only infection, but it will cause a thrombotic disease, pulmonary hypertension, and it is associated with the most of the morbidities. If you look into this slide that Khaled showed you, and you look into the red lines, you will see that all the ineffective erythropoiesis, hemolysis would lead to the hypercoagulability and would lead to most of these complications. And this is exacerbated, as you see from the red arrow, by splenectomy. We need things that will ameliorate this, not to exacerbate this. So splenectomy is really a major component in all morbidities that we see in NTDT. And this will show you the interaction of multiple risk factors for the morbidity of NTDT. So the orange circle is the ineffective erythropoiesis, anemia, hemolysis, iron overload in the red, splenectomy in the blue, and you would see that the majority of these complications are due to most of these complications together. Now, not only physically these patients will have lower health score, but these patients also will have lower mental health score. This is from an old study that we have done in Lebanon, and that we have shown that the scoring, whether health score or mental score, in the NTDT or in the beta thalassemia intermedia is lower than those in the TDT or beta thalassemia major. So we will move now into the management of NTDT. So Khaled will be continuing.
Thank you, Ali. So we're gonna split the management component into two parts: the conventional management, what's available today, and what we're hoping to have soon through clinical trials and novel therapies. So this is again the let's say the algorithm for management that we put the guide for management in the recent New England review. And you see that when we look at the lower part of the figure, the iron overload story seems a little bit more established now onto when and how we should treat patients, while the anemia, and I will go into that shortly. But when it comes to anemia, we don't currently have any approved therapies for the management of anemia and NTDT. And what we're currently saying is that most of these patients should be considered for clinical trials evaluating novel therapies for patients with a certain hemoglobin level, usually less than 10. Otherwise, transfusions are what's left to use. And I will go over the evidence we have in terms of using transfusion therapy in an NTDT patient population. We cannot today recommend transfusion for all NTDT patients. The reason being is that as much as we see that transfusion ameliorates the underlying ineffective erythropoiesis and corrects anemia, we don't want to create the same story as we have in TDT when it comes to secondary iron overload. That's why, at the moment, at least in the international guidelines, we're looking at certain groups of patients that could benefit from some form of transfusion therapy, even if frequent or regular transfusion therapy. And these would be in situations of growth challenges during childhood, or when there are impending or overt or established clinical morbidities where there is some sort of evidence that a short or maybe intermediate transfusion, a regular transfusion program could be of benefit. This is data from Viprakasith that looked at the use of transfusion and NTDT, specifically hemoglobin E beta thal patients, to promote growth. And it's clearly patients who had received transfusion actually had a better growth measures or metrics over time. And this is data from the optimal care study that Dr. Taher showed earlier, where we looked at the role of certain interventions that were being used across the region that we evaluated. And it was clear that transfusion therapy was associated with lower rates of specific complications like pulmonary hypertension, AMH, thrombosis, for the reasons that Dr. Taher alluded to earlier. Because the transfusions wash out these pathologic RBCs that can lead to thrombosis, for example, or they balance out the ineffective erythropoiesis, which is leading to the various morbidities. But definitely that was obviously at the expense of increased endocrine disease, for example, due to iron overload. This is data from recent data, actually, that we had from a very large data set from the International Working Group on Thalassemia, a database based at Palermo, Italy, with Professor Aurelio Maggio, with a large group of patients included from various centers, including also involvement of Dr. Ali Taher, Dr. Amal Bishlawi. The first thing we did is we looked at survival in NTDT patients, and that was the first time we were able to do that because of the size of the patients that were included in this registry. And you can see here that the leading causes of death. First of all, this graph on the left maybe it cannot be interpreted without some sort of relevant control, but we were able to show that survival in general is lower than that you would see in the non-thalassemic population. But the most important piece of information that came out with is that the leading causes of death were clarified, and that included cardiovascular disease. But mind you, that's not the typical iron-related cardiomyopathy. Actually, only 2 patients died from iron-related cardiomyopathy. Most of it was related to pulmonary hypertension, thrombotic disease, so under the umbrella of vascular disease, not necessarily iron-related heart failure, for example. And the second leading cause of death was hepatic disease, fibrosis, cirrhosis, and HCC. And a lot of patients actually died from cancer, some solid or hematologic malignancies, which we're seeing more and more common, not necessarily only because of iron overload leading to HCC, but also due to the aging population and the stress the ineffective erythropoiesis is causing on the bone marrow. So you see actually a higher rate of hematologic malignancies sometimes in these patients than in non-thalassemic patients. And when we looked at those patients that received transfusion at some sort, regular transfusion at some sort of time during their their life. It was clear that patients who received transfusion fared better. They had lower rates of morbid mortality. Most of those patients received transfusion at the median age of 10 years. So you see how delayed it is compared to TDT. But it was clear that those the group of patients that received that regular transfusion therapy actually had better survival. So again, back to the point that I made earlier, this gave us a very clear documentation of something that we knew already, clinically speaking, that transfusions are actually reversing the underlying pathophysiology in these patients. But again, we're still looking today to not even require to give these patients transfusion through the novel therapies that we will feature later on in the presentation. Because if we have a tool that will allow us to increase the hemoglobin level without having to rely on transfusion and all their side effects, that would be the ideal for both the patients and the treaters. And when it comes to iron overload, again, I mentioned that when we talked about iron overload earlier, but it was clear to us which patients actually would require management of their iron overload. These are the NTDT at the age of 10 years or older. We usually quote a higher age for hemoglobin H disease because the rate of iron overload from intestinal absorption is slower actually in alpha thalassemia than it is in beta thalassemia. And then with regular screening through serum ferritin or LIC, depends on the availability, we indicate iron chelation therapy for patients with a serum ferritin more than 800 or LIC more than 5. And the data on iron chelation therapy efficacy and safety came from the THALASSA trial with the ferrosirox that Professor Taher led. And in this study, it was very clear that the ferrosirox was able to lead to an effective reduction of liver iron concentration over 2 years, at least from this published data that's here in the graphs. And that was the first trial that's specifically looking at iron chelation therapy in NTDT and in specific in patients that do not receive transfusions. We also obviously have from that database that I mentioned earlier from the International Working Group, we were able also to look into the use of chelation therapy and its effect on mortality and morbidity. Obviously, this is a historic database. So for patients that receive different types of iron chelation therapy, whether they were on label or off label at the time in the past. But it was also clear that when looking at mortality from hepatic disease specifically, there was a lower mortality rate in those who received iron chelation compared to those who did not. And management of NTDT, we need to remind everyone that it's not all about improving hemoglobin level and managing the extra iron or the iron overload. So in most of the patients, especially the adults, morbidities have already manifested and they require special care. And we've published over the last few years several guides on how that can be done. Obviously, the reference book is always the guidelines from TIF, but we also have some practical reviews on how to deal with adults in specific and manage pulmonary hypertension, thrombosis, liver disease, usually in consultation with a multidisciplinary team. But we need to remember that patients, most of the patients today already have some sort of morbidities that require special attention. And back to Dr. Taher to walk us through also novel therapies in thalassemia in general and TDT in specific.
Thank you, Khaled. So I'm sure during this meeting, Professor Capellini and Dr. Katamis will be talking about some of the novel therapies. However, I would like to highlight this publication that we have published recently, also that has all the updates on all clinical trials in beta thalassemia, specifically including the NTDT one. This is a very interesting slide that shows you that there are 3 components of the novel therapies. One of the components is to act on ineffective erythropoiesis, and this is what I will be highlighting. The other 2, one is the gene therapy, gene editing, and the other one is to act on iron regulation. So I will be highlighting the effect of targeting ineffective erythropoiesis in increasing hemoglobin, specifically in this group of patients. So let me talk about, very briefly, you will be having a specific presentation on luspatercept. Luspatercept is an erythroid maturating agent that acting on the late stages of erythropoiesis. It's the first-class erythroid maturating agent. It neutralizes TGF beta superfamily ligands to inhibit the aberrant SMAD2/3 signaling, and it enhances late stage of erythropoiesis. These are some of the studies on luspatercept. One of them is a BELIEVE study, which is already published, and it is the study through which the FDA approved luspatercept in transfusion dependent. But what I'm going to highlight is the BEYOND trial. But before going into the BEYOND trial, I'll just show you from one of the phase 2 trials that were done on luspatercept, smaller trials. It showed that luspatercept improved hemoglobin level and decreased blood transfusion if needed in this group of patients. This is a slide showing you the improvement in one of the complications that Khaled discussed, the leg ulcers in those patients receiving luspatercept. But I will highlight here our phase 2 randomized clinical trial of luspatercept in adult patients with NTDT, the BEYOND trial. This was presented in the presidential symposium during the EHA 2021. After screening, these patients were randomized into a luspatercept arm, 1 milligram per kilogram subcutaneously every 3 weeks versus the placebo arm. And then after year 1, it became an open label study. So the primary endpoint was an achievement of an increase of 1 milligram, 1 gram per deciliter of hemoglobin. And the key secondary endpoint, which is really very important, which is related to the quality of life, is the mean change from baseline NTDT, patient-reported outcome, tiredness, and weakness score. The study met its primary endpoint. As you can see in this slide, around 77% of patients who were on the luspatercept arm versus 0% of the placebo patient achieved an increase in hemoglobin of more than 1 over a continuous 12-week interval. And if you look specifically into an increase of 1.5 gram, so during week 13 to 24, around 50% of patients in the luspatercept arm achieved a hemoglobin increase of more than 1.5 gram per deciliter. And Khaled have shown you clearly from one of our studies that an increase of hemoglobin by 1 in this group of patients will decrease the morbidities. This is the specific NTDT patient-reported outcome score that we have developed and validated, and this was published in 2 papers in the American Journal of Hematology. This is the secondary outpoint from the BEYOND that shows us that NTDT PRO, tiredness and weakness domain score improved in those that increased their hemoglobin. This is really very important. All those that increased their hemoglobin improved in their tiredness and weakness and their PRO score. Now, Khaled will continue with some of the novel therapies.
Yes, just to also complete the picture in terms of the current agents in development that would target ineffective erythropoiesis. So we have mitapivat, AG348. It's a PK activator that started being developed for pyruvate kinase deficiency, but there are also indications that the ATP supply is insufficient in thalassemia, which makes this, let's say, an agent of interest. And in mouse models in beta thalassemia, there was also enough data to show that using mitapivat reduced the markers of ineffective erythropoiesis, improved the anemia, improved RBC survival, which prompted the development of the product in thalassemia in clinical studies. And currently, this is the trial landscape for mitapivat. There is a phase 2 study which has already some data that I will share on the next slide. But interestingly, the improvement in hemoglobin of 1 gram is also here as an endpoint, and the population of NTDT that's also being looked at in terms of eligibility are those with a hemoglobin of less than 10, and these are for the reasons that we mentioned earlier in the presentation in terms of how we see hemoglobin risk in these patients. The two phase 3 trials that are designed, and you can find their details on clinicaltrials.gov. One is actually going to be conducted in transfusion-dependent patients, and one in NTDT patients. NTDT, that's for transfusion reduction, as you would expect, but again, for NTDT, it's to increase hemoglobin level by at least 1 gram per deciliter, with several other secondary endpoints to confirm the benefit that you see from hemoglobin increase. And this is the interim data that was shared originally at ASH and then again at last EHA, where you could see that 11 out of the 15 patients had the improvement of hemoglobin at of 1 gram per deciliter and above at 12 weeks. And we do expect to see more and more data from this trial, but we're also eager to see the phase 3 trials commencing so that we can look at the benefit in a randomized controlled environment. In the figure that Dr. Taher showed, in that figure looking at novel therapies, the other pathway that's being looked at to address the unmet needs in NTDT is looking at the hepcidin dysregulation. As we mentioned earlier, that since hepcidin levels are low and this is leading to the increased intestinal iron absorption, originally these therapies that are targeting the hepcidin pathway were looking at preventing the iron overload through increase in hepcidin level and decrease in intestinal absorption. But in most of the mouse models that were tried, you also see the effect on hemoglobin, because we do know that we have a bidirectional relationship between iron overload and ineffective erythropoiesis. So these agents actually are now being evaluated in NTDT for a primary endpoint, again, of hemoglobin increase, because as much as they do prevent iron overload and can lead to iron decrease, but they also improve hemoglobin level, and that's what they're being evaluated for. There were some studies that were started in with the use of mini-hepcidin, but mostly in TDT patients. But with NTDT, we have what we call stimulators of hepcidin production, the TMPRSS6 ASO, it's an antisense oligonucleotide, and we have the siRNA, also SLN124. These studies are ongoing. We don't yet have data from them to share with you, but we're hoping to see data coming up shortly for these studies. And again, along the same pathway, we have a ferroportin inhibitor, BIT2763, that's also being evaluated now in a phase 2 randomized placebo-controlled trial, again, for a primary endpoint looking at hemoglobin change. Again, we're also expecting to see data hopefully soon from this trial. And maybe to conclude, myself and Dr. Taher all together, that as much as we know that the iron overload story probably in NTDT has witnessed a swift evolution in the last 10 years with the availability of iron chelators specifically approved and developed for NTDT, but we still have a challenge with the anemia, as much as transfusions are there to treat patients with as needed. But we're looking forward to see all the data from these novel therapies that are aiming to improve hemoglobin level. And assuming that all of these therapies do show some sort of efficacy and safety, we will end up with various agents, and then that will obviously open the door to questions about combinatorial or combination therapy, whether it's between the conventional iron chelation or even transfusion and those agents, or between the agents themselves, so that we can have all the pathophysiologic mechanisms addressed in one way or another for these patients to prevent the future morbidity.
So although, as Khaled said, that the future, there is a future in treating these patients either by the novel therapies or by the combination therapy. However, I think that there are some lessons that every hematologist or physician that see thalassemia should learn. Still, we need to know when to transfuse these patients. Still, we need to chelate these patients. Still, we need to avoid splenectomy, because we have shown clearly that all of these splenectomy is a main component in developing morbidities. I'm sure that these novel therapies will not be available for every country at the same time, in the same period. So one should even remain understanding well the conventional therapy in order to prevent most of the morbidities of our patients until novel therapies are available, and until hopefully combination of novel therapies and iron chelation therapy would be available for each and every one of our patients. So I would like to thank you for listening to both of us, And I would like to thank specifically once again, Professor Amal Bishlawi for including us in her meeting. And hopefully next year we will be in Cairo together with you.
And I thank you again, and I hope you enjoy the rest of the meeting. Thank you.
Thank you. Thank you.